Good evening, guys. Welcome. I hope you're all doing well. Um, Today we will be talking about fluids and electrolytes, one of the most fundamental concepts that we need to understand in nursing. Um, this can be really, really wet, but this can be really, really dry in terms of discussion. Again, like I said, this is one of the most fundamental concepts that we need to understand. A lot of concept in in nursing is related to fluids and electrolytes, and of course, acid-base balance. We'll talk about more of that later. If we're talking about fluids and electrolytes, it's important to understand that this fluid and electrolyte balance is key to maintaining homeostasis. And what is homeostasis? Homeostasis is technically defined as the internal balance, internal milieu, and this is necessary in order to ensure that the entire system of the body and all the cells are functioning effectively in order to maintain the normal functioning of the human organism. Now, in order to maintain internal balance, the body must be able to regulate the internal body fluids. Of course, body fluids are important in maintaining regulatory function of the cells, regulatory function of the organs, and all of these organs and structures of the body uh, is dependent or are dependent in the stabilization and internal balance uh, and homeostasis in order to function effectively. So, when you say when we talk about homeostasis, we talk about internal balance. Of course, the main concept that we need to understand is what are the fluids that are responsible for maintaining homeostasis. And if we talk about body fluids, you have to remember there are two compartments of the body where you can find body fluids. Um, Body fluids are usually found inside the cells. In such case, these are called intracellular fluids, and all of those fluids outside the cells are called extracellular fluids. But when you say extracellular fluids, um, the extracellular fluids are further subdivided into two. Those who are outside the cells, but they are inside the blood vessels, like this one, um, which they are considered or called intravascular fluid, and there are extracellular fluid that are outside the cells, but also they are not inside the intravascular compartment. Um, they are more in between the cells and around the cells, and these are called interstitial fluids. So, if somebody asks you, how many compartments or fluid compartments do we have in our body? The correct answer would be two. We have intracellular fluids, those fluids inside the cells, and extracellular fluids that are outside the cells. And extracellular fluids, again, like I said, is divided into two. Those who are inside the blood vessels are called intravascular fluids, and those that are outside the blood vessels and outside the cells and so they are in between the cells. They are called extracellular fluid interstitial compartment. So, um, what are the composition of body fluids? There are only two things uh, composing your body fluids. You have the water, which is the main, composition, and of course all the dissolved substances in the water called the solutes, and those solutes involve or includes vitamins, minerals, even gases are all part of this what we call solutes. So when you say body fluids, you refer to the water and its dissolved substances in the body. Of course, water is the main component, and it is very important to understand that these body fluids composed mainly of water and dissolved substances are important in regulating body functions, the regulation of our system, the organs, and everything. Um, since water is the most or the major component of body fluids, we have to understand why water is important to all living cells. Water is a universal solvent. You can mix water with almost anything, with the exception of course, of oil. So it's a universal solvent. It's a very good medium for transporting solutes, vitamins, minerals, blood cells from one part of the body to the other. And since water is an electrical conductor, so it helps in metabolic reactions. So just like some cells of the body, like the neurons of the nervous system, they communicate with each other by using electrical impulses. And these electrical impulses will not take place unless you have the water serving as the um, electrical conductor, causing metabolic reactions. Um, if you compare the distribution of body water between an average adult male and an average adult female, you would notice that an average adult female um, will have about 54% of their body weight attributed to fluids and only 46% to solids. Of course, different books will give you different, you know, percentages, but it's consistent that you would notice that in every book, male has more um, body fluids compared to female, which is approximately 60%, and 40% of the male body weight is attributed to solid parts like the bones, the muscles. So if you compare between an average adult female and an average adult male, then it's clear that male has more body fluids loose, and so therefore they are more susceptible to dehydration. Female has a little more stable um, distribution of body fluids and of course solids. That's why they are less susceptible to dehydration. Um, the percentage of body water, depending on age and gender, you would notice that if somebody asks you who will be more susceptible to dehydration, well, the best answer would be the very very young and of course the very old. Why? Because the very young, like infants and neonates, 75% of their body weight is due to water. This is the reason why if an infant is getting dehydrated, their condition um, can go downhill really fast because 75% of their body weight is due to water, and if they lose a lot of water, such as in the case of diarrhea, um, then they will be losing a lot of their body weight, and it could be detrimental to their health, and their condition can get worse and really fast. Um, Likewise, the very old is also susceptible to dehydration, not because they have more body fluid, but because they have less water to lose. Only 45% of their body weight is due to fluids or body water, and so another group that are susceptible to dehydration would be your elderly patients because they have less water to lose. Um, So again, in review, what are the compartments of body fluid? Again, you have only two compartments. One, those fluids inside the cells, which we call intracellular fluids. A majority of our body fluids are due to, or majority of our body fluids rather, are found inside the cells, and we also have fluids that are found outside the cells, but inside the blood vessels, and they are called, of course, intravascular fluids, and there are fluids in between the cells called interstitial fluids. Um, so here, this is an illustration or the distribution of our body fluids. A lot of books will say 40% of adult male and female total body weight is due to the intracellular fluid, and about 20% of the total body weight is due to extracellular fluid, which is again divided into intravascular and interstitial fluid. So where can you find the intravascular fluid? Majority of them are, of course, in the plasma, or I guess I could say all of them are in the plasma. About 3 to 5 liters of fluids are in the plasma, mixed with the blood, of course, and those fluids that are in between the cells, about 80% of the extracellular fluids, those are interstitial fluid. And then we have some fluids that are actually produced or secreted by some organs and some cells of our body, like the lymphatic fluids, the cerebrospinal fluid, the gastric juices, synovial fluid, which are, found in between the joints, the aqueous humor and the vitreous fluids, which are found in the anterior chamber and posterior chambers of the eyes. We have the endolymph, the perilymph in the um, inner ear, and we have serous fluids and glomerular filtrates. This is just another picture of how um, interstitial fluid, intravascular fluid, and intracellular fluids are illustrated. Again, those who are fluids inside the cells, the cytoplasm and nucleoplasm, are called intracellular fluids, and fluids that are outside the cells are called extracellular fluids, divided into two. Those that are inside the blood vessels are called the intravascular fluids, and those that are outside the cells but in between and around the cells are called interstitial fluids. So the largest portion of the body weight, as you can see, is due to body fluids, and of course, the percentage is affected by age, sex, and distribution of body fat. That's one of the reasons why male is more susceptible to dehydration compared to female, because female have a lower percentage of body water than male throughout adult years, since women have more adipose tissues, and women are actually lucky because you are protected by some hormones secreted by your gonads, like the estrogen, progesterone, that helps distribute body fat all over the body. Whereas male, if we're growing big, our adipose tissues are just concentrated in our tummy and in the heart, and that's why before the age of 65, male are also more susceptible to cardiac disorders compared to women, because we don't have that protection um, provided by your estrogen and progesterone. Um, so we also talk about dissolved substances in the body fluids, and again, like I said, the main composition of your body fluids are just simply water and dissolved substances. And part of those dissolved substances are electrolytes. And these electrolytes are substances that break down into ions when placed in water. And what are ions? Ions are chemicals active in body fluids, and they are capable of creating electrical impulses. There are two types of electrolytes in body fluids. Those that has positive charge are called cations, and the ones with negative charge are called anions. Their strength is, of course, expressed in milliequivalents per liter. Um, I just want to clarify that there are some electrolytes that are also considered minerals. A good example of that would be calcium. Calcium is a mineral, but at the same time, calcium is a cation because it has positive charge. There's another one, magnesium is also an electrolyte, but at the same time, it's a mineral of the body. So, in a solution, um, the cations and anions should be equal in strength in order to maintain a stable solution. So if I have, for a mathematical illustration, if I have 50 cations in a solution, I should have 50 anions in a solution as well. The only difference would be between the intracellular fluids and the extracellular compartment. There are electrolytes that are inherently intracellular, and there are electrolytes that are usually stays outside the cells, and they stays in the extracellular compartment of body fluids. Um, of course, there is we don't have a technology yet capable of measuring the amount of electrolytes inside the cells unless you extract all the fluids and electrolytes of each cells, which we have trillions, of course. So right now we don't have any capability to measure the amount of electrolytes inside the cells, but we have um, an ability to measure the amount of electrolytes in the plasma or in the blood, and so therefore, if we can measure the amount of electrolytes in the plasma or in the blood, then um, we can deduce or we can assume how much electrolytes are actually inside the cells, be it a cation or an anion. So, what are some of the main electrolytes in body fluids? Sodium is one of the most common electrolytes, or one of the main electrolytes. We have chloride as well, magnesium, calcium, and potassium. Potassium and magnesium are basically intracellular cations, whereas calcium and sodium are your cations outside the cells, or extracellular cations. So let's look at this. What are the major functions of your electrolytes? Of course, for water distribution, and just like what I said earlier, these electrolytes are capable of creating electrical impulses by electrical discharges. You have positively charged cations, and you have negatively charged anions that can actually cause reactions and create impulse transmission by conducting electrical impulses, leading to muscle movement and, of course, function of certain cells, leading to secretions of certain hormones, certain enzymes as well. Another major functions of these electrolytes is to maintain acid-base balance and to maintain homeostasis or internal milieu. Again, like I said, earlier, maintaining that internal balance is critical in maintaining the normal functioning of each and every organ of the body. and thus maintaining the function of the human organism. So, again, to review, what are the major electrolytes in body fluids? We have cations inside the cells, so these are the intracellular cations, but particularly magnesium and potassium. And we also have cations or positively charged electrolytes outside the cells or in the extracellular compartment, basically your sodium and your calcium. The anions are phosphate and proteinates in the intracellular, and we have chloride and bicarbonate in the extracellular compartment. I need you to understand that, in order, again, remember what I said earlier, in order to maintain a stable solution, we need to have an equal amount of cation and anion in a solution, just to make that solution stable. So if you mix, let's say, for example, potassium and phosphate, then you can come up with potassium phosphate or K phos. Um, Magnesium can be mixed with phosphate as well, and that will create your magnesium phosphate. Likewise, sodium can be mixed with chloride in the form of sodium chloride, basically your NaCl, your table salt, and NaCl is also your normal saline solution, and it's a stable solution. Calcium can be mixed with chloride as well, like in calcium chloride, um, a solution usually found in most dental, dental equipments or dental, like toothpaste, for example. Um, Also, sodium bicarb can be sodium and bicarbonate can be mixed together in the form of sodium bicarbonate. Um, Calcium and bicarbonate can be mixed together. Calcium carbonate, like Tums, those uh, what they call this, anti-acidic medications that you usually found in grocery stores like Costco, for example. So calcium carbonate, I think Rolaids is also calcium carbonate. Uh, Potassium chloride are two combinations that you usually see being mixed together also. And you also have magnesium chloride or magnesium bicarbonate, one of the most common laxatives available in the market. So again, like I said, these cations and anions need to be equal in amount in a solution in order to create a stable solution. So what are these chemicals again? We have sodium and calcium as extracellular cations, and we have potassium and magnesium as intracellular cations. So basically, these are inside the cells, and calcium and sodium are outside the cells. Your chloride, phosphate, and bicarbonate, and of course proteinates are your anions. Um, these are the normal values of the most common electrolytes that you will find in body fluid, and you need to memorize these values because you will be using this not just for fundamentals, med surge 1 and med surge 2, pharmacology, and even for NCLEX. So please make sure that you remember this, commit this to memory because by module 4 you need to make sure that all of these are embedded in your DNA. And so if somebody asks you what's the normal value or serum level of sodium, then it should be instant. It's 135 to 145 milliequivalent per liter. Potassium is between 3.5 to 5.5, calcium 4.5 to 5.5. Magnesium is 1.5 to 3.0. A lot of doctors usually will maintain or will want to maintain a magnesium level of 2.0, chloride between 98 to 106, the phosphate 1.2 to 3.0, and bicarbonate, make sure you remember this is 22 to 26 max per liter because you will be using this for interpreting acid-base balance as well. So the most abundant electrolyte is of course sodium, and this is primarily found in the extracellular fluid. It regulates body fluid volume, muscular activity, nerve, impulse conduction, and acid-base balance. The only way to eliminate sodium from the body is by sweating. I don't know if you noticed this, but your sweat is a little salty uh, because it contains a lot of sodium. The kidneys can also eliminate sodium or excess sodium by urination. Vomiting and diarrhea will also cause you to lose some sodium. Um, if your sodium level in the blood is less than normal, then the condition is called hyponatremia. And if a patient is having hyponatremia, patient may have a decreased level of consciousness. The patient may appear lethargic, a little sleepy, a little confused. The patient will be complaining of headache, apprehension. Patient may go into seizures or even lead to a coma state. So hyponatremia is when the serum level of your sodium falls below 135 max per liter. And again, some of the possible causes will be intestinal suctioning or even, vomiting, almost the same thing. If you're having loose bowel movement or diarrhea, you're not using salt, adequately. You're taking some medications like diuretics that can actually help in, removing sodium from the body that can lead to hyponatremia as well. And this shifting of fluid from intracellular to extracellular by hypertonic solution like mannitol. If you don't know what mannitol is a hypertonic solution that helps draw fluid from the interstitial and intracellular compartment, and it will bring this fluid to the intravascular compartment so it can be eliminated from the body. A lot of times mannitol are being used to reduce edema of the brain tissue in case of increased intracranial pressure. Nursing management for hyponatremia, you need to check for the input and output of the patient, weigh the patient daily. By the way, one of the if somebody asks you, or even in NCLEX, if there's a question about what nursing intervention would be the most accurate way of monitoring the fluid status of the patient, the answer would be daily weight or weighing the patient daily, um, and monitoring the input and output of the patient is just secondary. Um, you need to monitor the urine specific gravity as well. I'd like you to remember the urine specific gravity is between 1.010 to 1.025. So you may need to jot that down. Again, urine specific gravity is between 1.010 to 1.025. So if a patient is excreting large volume of urine and the specific gravity is less than 1.010, then it means that the patient is excreting diluted urine, and that could mean that the patient is, you know, having edema, but at the same time, the patient can be susceptible for dehydration as well if the patient uh, lose a lot of fluids. Any urine specific gravity higher than 1.025 usually indicates dehydration because it means that the kidneys are not producing adequate amount of urine and the urine produced is of course concentrated, a lot of times that's a sign of dehydration. So check and compare daily weights. Again, the daily weight is the most accurate way of assessing the body fluid, or whether the patient is maintaining good body fluids. The intake and output record will just be secondary. Watch for pitting edema, because pitting edema usually suggests um, retention of body fluids that may be associated with delusional hyponatremia. The flip side of hyponatremia is hypernatremia. So any um, blood sodium level higher than 145 mg per liter will be considered hypernatremia. And what are some of the causes of increased sodium level in the blood? Of course, medications uh, can can increase the sodium level in the blood, or some medications. Um, if you like eating salty foods or high sodium diet, like canned goods or processed meats and everything, those are also sources of high sodium diet. Osmotic diuretics, again, like I said, I mentioned something about mannitol earlier. Diabetes insipidus. If you're not familiar with diabetes insipidus is an endocrine condition where the patient has less secretion of a hormone that helps in maintaining body fluids and preventing too much loss of body fluids. Um, that hormone is called antidiuretic hormone, or ADH, secreted by the posterior pituitary gland. So if the posterior pituitary gland is not secreting adequate amount of antidiuretic hormone, or sometimes known as vasopressin, then the patient will be diagnosed with diabetes insipidus. And if the patient has diabetes insipidus, there is a big chance that the patient will be losing a lot of fluid because he doesn't have enough hormone that will help in keeping the fluids inside the body. Excessive water loss can also cause um, hypernatremia, simply because if you lost too much fluid, then the blood will become concentrated. And if you obtain a sample of blood, then the amount of water compared to the solutes will be much less, and so that will make a very concentrated blood, and the sodium level will be high as well. And of course, if you're not taking or ingesting adequate amount of water, then you will be susceptible to dehydration and hypernatremia as well. Um, so, what are some of the mechanisms of hypernatremia? Um, Again, hypernatremia, any sodium level higher than 145, or some books will say 147, um, will be considered hypernatremia. And what will happen is, um, if the patient has a sodium serum level higher than 145 or 147 in this case, there are several things that the patient will feel. First, the patient will feel really, really thirsty, because this could mean that the blood is concentrated. The pituitary gland will be releasing antidiuretic hormone. So, once the antidiuretic hormone or the vasopressin is released, then the kidneys will try to conserve water in order to somehow dilute the blood and prevent it from being too concentrated. That can lead to several complications like blood clot formation and everything. So when antidiuretic hormone is released, then the kidneys will reduce the amount of urine being produced per hour, thus keeping some of the fluids, preventing further dehydration and the blood becoming too concentrated. The brain, the hypothalamus will also uh, kick in, and the hypothalamus will activate the thirst center and making the individual or the human organism um, ingest more fluids in order to quench the thirst. And this is a mechanism also that can help us prevent dehydration. Um, so, these are some of the things that will happen inside the brain and inside the body, just in case we're losing too much fluid or we're becoming a little dehydrated, that can lead to hypernatremia. So, what are some of the signs of hypernatremia? There's a lot of mnemonics that you can use, but I found this one. It says fried. First, patient will experience fever, maybe low-grade fever, flushed skins. Why fever? Again, remember, hypernatremia is usually associated with dehydration. And so, if you're losing too much water, making the blood concentrated, you're also losing the cooling effect of water coming from the inside, and so it can lead to an elevation of body temperature. And because you have elevated body temperature, the blood vessels will become dilated as well, leading to flushed skin. Irritability, restlessness is also part of the signs and symptoms, because if you don't feel good from the inside, you have low grade fever, then of course that can lead to irritability. Increased fluid retention, maybe an increased blood pressure. This is secondary to decreased urine production and of course secretion of those antidiuretic hormones. If you retain fluid because of this, then a patient may have edema, peripheral edema, or pitting edema. And of course, the urine output will be less. Patient will have dry mouth, all sign of dehydration. How do we manage hypernatremia? Again, um, 24-hour intake and output, measuring daily weights, very, very important. Checking urine specific gravity, and most likely, if the patient is dehydrated, again, the urine will be concentrated, leading to a higher specific gravity, greater than 1.025. Watch out for tardy pulses, um, flat neck pains, that could all indicate dehydration. Changes in sensorium, the patient may appear a little confused, um, lethargic maybe, and of course, because of dehydration, there will be fast heart rate and of course an increase in respiratory rate. You have tachycardia and tachypnea. Okay, potassium. Potassium is one of the most important electrolytes of the body, and potassium are found mainly inside the cells. They are the major cations in the intracellular compartment. This potassium is important in maintaining fluid osmolarity and volume within the cells, and of course, they are needed for protein synthesis. Um, they help in normal membrane excitability. They also help in the synthesis and breakdown of glycogen. And what are those glycogen? Those are stored glucose in the muscles and in the liver. And we use those glycogen for energy in case of emergency. If you remember the local adaptation syndrome and the general adaptation syndrome by Hans Selye, usually referred as the fight or the flight response. The only way to eliminate potassium from our body is through the kidneys, the genitourinary system. So the kidneys are capable of eliminating excess potassium from the body through the urine. So you can probably deduce right now that if the kidneys are damaged or if the kidneys are not fully functioning, then we will have a problem in eliminating excess potassium from our system, and that can have a very bad, impact or side effect to the function of the body, particularly the heart. Any excess in potassium can cause cardiac dysrhythmias, the same way that a decrease in the potassium level in the blood will also have a deleterious effect or effects in the cardiovascular function. So you have to remember any increase or decrease in the potassium level, hyperkalemia or hypokalemia, will both have a detrimental impact to the function of the heart, and it can cause cardiac dysrhythmias. So the kidney functions or the kidney function in maintaining the potassium level in the blood is really critical. So any damage to the kidneys will will um, will create a big impact to the function, not just of the heart, but of the muscles as well. What are some of the causes of an increased potassium level in the blood? We have medications that can cause increased potassium level, like ACE inhibitors, non-steroidal anti-inflammatory drugs, um, and any type of acidosis, whether it's metabolic or respiratory acidosis, will push potassium out of the intracellular compartment, and they will go to the intravascular compartment that can lead to hyperkalemia. Cellular destruction, such as in the case of burns, traumatic injury of the muscles and tissues, will again squeeze potassium out of the cell, and that can lead to hyperkalemia as well. Decreased secretion of aldosterone, such as in the case of hypoaldosteronism. Remember, aldosterone is the hormone responsible for reabsorbing sodium, and if you don't reabsorb sodium, then you will lose sodium, and potassium will come out of the cell, and potassium will stay in the blood vessels. So it's like sodium and potassium, they have a love and hate relationship. If there is sodium, you won't find potassium, or there is very little potassium if you have sodium in the extracellular compartment. But once you lose the sodium, then potassium will come out of the cell, and potassium will stay in the blood vessel. So there should be a good balance between the sodium in the extracellular compartment and the potassium in the intracellular compartment in order to prevent hypo or hyperkalemia. Destruction of the cells, such as in the case of hemolysis, will also release potassium in the blood. Remember, all blood cells contain potassium, and so once you destroy those RBCs, then potassium will be released in the blood. That can lead to hyper-K as well. Excessive intake of potassium can also cause hyperkalemia, obviously. And with this, you have to remember what are some of the foods or food supplements that are high in potassium. Um, Foods that are high in potassium, you have bananas, cantaloupe, apricots, watermelon, salmon. There's a lot. Aside from salt substitute, a lot of doctor will say, if you have congestive heart failure, you have edema, you have to reduce your sodium intake. So avoid using table salt, because table salt are sodium chloride, and use salt substitute instead. But you have to remember that most salt substitute substitutes available in the market are, yeah, they are not sodium based, they are potassium based. So instead of having NaCl, most of these salt substitutes are KCl, or potassium chloride. And so if you're using potassium chloride and you're using that excessively, then yeah, you will not have edema, but you can have cardiac dysrhythmias due to an increase or excessive intake of potassium. Again, I told you the only way to reduce potassium in the system is through elimination by the kidneys. So you can probably deduce that if the patient has renal failure, then it will be very, very hard for the patient uh, to excrete excessive potassium from the system. This is the reason why patients with end-stage kidney disease or kidney failure will need dialysis, and it's not because they want to clean the blood. Of course, that's secondary. Uh, the primary reason why they need dialysis is because they need to wash the blood and remove excess potassium from that blood, since it can trigger um, not just involuntary muscular contractions, but also cardiac dysrhythmias. So, if you have impaired excretion of potassium, such as in the case of renal failure, then yes, you are susceptible, or you will be susceptible to hyperkalemia that can lead to cardiac dysrhythmias. So, what are some of the symptoms? Muscle twitching, muscle cramps, paresthesias, irritability and anxiety. These are just changes associated, or signs and symptoms associated with hyper K. Blood pressure may drop significantly. You will see some EKG changes, like an elevation of the T wave, or tenting of the T wave. Maybe we can talk about that in med surg. This is what we call peak T wave in case of hyper K. Cardiac dysrhythmia, so irregular heart rhythm, usually it can lead to cardiac arrest, or development of PVCs, ventricular fibrillation, or even ventricular tachycardia. I'm sorry. Abdominal cramping, and usually hyper K is associated with diarrhea. Okay, so again, if you want some mnemonics in order to remember some signs and symptoms associated with increased potassium level in the blood, remember MURDR, murder. It will cause muscle weakness. It can cause oliguria or even anuria if you have, decrease in output secondary to kidney failure. It can lead to respiratory distress, decreased cardiac contractility, even cardiac dysrhythmias, peak T wave in EKG, flaccid reflexes, and even hyperreflexia sometimes. Now, how do we manage, hyper K? A lot of people will say hyperkalemia is murder, so you need to treat your patient with a little kindness. Kindness, basically, Kayexalate. If you don't know what Kayexalate is usually given to patients with hyperkalemia in order to exchange sodium with potassium in the gut, and instead of eliminating potassium through the kidneys, then potassium will be eliminated through the GI tract by exchanging sodium with potassium. Insulin will also help. Why? Because insulin helps in driving glucose from the blood into the intracellular compartment, and in that process, it will also drag potassium with glucose, helping reduce potassium in the blood. sodium bicarbonate, and some diuretics. But you have to remember, diuretics will be effective only if the patient has a fully functioning kidneys. If the patient doesn't have fully functioning kidneys, such as in the case of renal failure, then you cannot use diuretics. Potassium deficit or hypokalemia, a lot of times hypoK is associated with alkalosis. It doesn't matter whether it's respiratory or metabolic alkalosis. Most likely the patient will have hypokalemia. It can also lead to shallow respirations, irritability, confusion, and drowsiness. I told you earlier, whether it's hypo-K or hyper-K, it can lead to irregular heart rate, tachycardia, or even cardiac dysrhythmias, BTAC, ventricular fibrillation, and even formation of premature ventricular contractions. Patient's level of consciousness will decrease as well, leading to confusion, maybe lethargic level of consciousness, steady pulse, decrease in intestinal motility, leading to maybe ill use, and of course, patient will have nausea and vomiting. Um, Chloride is an extracellular anion. It's actually dependent mostly with sodium, and sodium and chloride are like Romeo and Juliet. They are inseparable. So you can probably deduce right now that when sodium is low, most likely you will see a low chloride level as well. Um the function of this chloride is basically to regulate osmotic pressure between fluid compartments, and they help in regulating acid-base balance as well. The only way to eliminate chloride from the system is through sweating, through the skin pores, vomiting, and through the kidneys as well during urination. Too much chloride is usually associated with too much sodium as well. Again, like I said, sodium and chloride are inseparable. They're like Starsky and Hutch. They're like Romeo and Juliet. They're like partners in crime all the time. So um, an increase in chloride level will suggest that the sodium is elevated as well. Um, the same way that if chloride is low, most likely you will see a low sodium level as well, or vice versa. A low sodium most likely will be associated with low chloride level as well. And again, if the patient has some kind of metabolic alkalosis due to losing too much hydrochloric acid, like vomiting, then you will see a low chloride level. Calcium is usually combined with phosphorus to form mineral salts of mostly bones and teeth. So again, like I said, although calcium is an electrolyte, you have to remember that calcium is also a mineral, and so sometimes if you're reading books and calcium is expressed in milligrams or micrograms, and you see a different blood level, uh, you have to remember that it that calcium may be considered as a mineral of the bones or of the teeth, and if it's between 98 to 106, and it's expressed in milli equivalent per liter, then most likely that calcium is treated as an electrolyte. So, where can we get calcium? Calcium is obtained by ingestion of calcium-rich diet, and calcium is basically absorbed in the intestines with the help of your vitamin D. So you have to remember, um, you cannot absorb calcium without vitamin D, and this is one of the reason why people who are taking calcium supplement, a lot of times, if you notice, most calcium supplements available in the market or in grocery stores or even in drugstores, usually they are combined or fortified with vitamin D, because it's futile to take calcium supplement without taking vitamin D. Calcium promotes transmission of nerve impulses, and they help regulate muscle contractions and, of course, relaxation. So, a low calcium level will cause problem in the relaxation of muscles, and that's the reason why a lot of times hypocalcemia or a low calcium level can lead to involuntary muscular contractions like positive Shubastics sign or and positive Trousseau sign. Shubastics is that involuntary muscular contraction of the muscle close to the cheekbone in response to tapping of that cheekbone right here. So if you tap the cheekbone like this, and the patient has hypocalcemia, most likely the patient will have involuntary muscular contraction called Shubastick sign. Um, Again, I like using mnemonics or even anagrams to remember some of these conditions, and I'd like to give you these CATs of hypocalcemia, CATS. Remember, if the patient has hypocalcemia, the patient may experience convulsions, involuntary muscular contractions like tetanic contractions right here, cardiac dysrhythmias, because calcium is also an electrolyte that helps regulate the electrical impulses in the heart, spasms, particularly of the muscles, and even respiratory muscles, and even your trachea, that can lead to constriction of the opening of the airways, that may lead to stridor, which is an emergency condition. So how do we manage hypocalcemia? Of course, if the patient has low calcium level in the blood, then the most significant nursing management and even medical management would be to give the patient calcium supplement and vitamin D supplement, such as you know um, foods that are high in calcium and foods that are high in vitamin D as well. Um, Remember also that calcium is a clotting factor. It's clotting factor number 4. If you don't remember the clotting factors, that's one of your assignment. We have um, 13 clotting factors listed, but only 12 are active. And clotting factor number 4 is your calcium. And so if you have hypocalcemia, then it means that you have less clotting factors, or less than normal clotting factors, and you will be susceptible to bleeding, like bleeding in the gums, bleeding from the nose, and all orifices. You know. This is what I was telling you earlier about Shabastic sign and Trousseau sign. Trousseau sign is involuntary flexion of the wrist and spasms and tingling sensation in response to compressing the arms or the brachial. Thank you very much. That's my wife right there. Um, Yeah, so hypocalcemia can cause involuntary muscular contractions, and worse, it could lead to seizure as well in extreme cases. Sorry. So, how about hypercalcemia? What's the danger of having hypercalcemia? Um, Hypocalcemia can cause involuntary muscular contraction, but hypercalcemia will cause a loss of excitability in the cell membranes, and it can lead to fatigue, weakness, decreased level of consciousness like lethargic level, anorexia, nausea, constipation, and remember this calcium can form crystals like calcium oxalates and calcium phosphates that can lead to calcium salts that can lead to kidney stones. And so um, taking or eating calcium rich foods or taking calcium supplement should be regulated as well. Otherwise, if you take too much, then yeah, you will not have osteoporosis, or you will not have involuntary muscular contraction, but it can lead to kidney stones. So it can also lead to some problems with the EKG. It may show shortened QT segments, depressed T waves. Remember, the T waves can be peak in case of hyper K, but in case of hypercalcemia, the T waves will be depressed. Magnesium is a cation, usually found, of course, in the intracellular fluid. They are usually found inside bone cells as well. 39 to 49% are found inside the intracellular compartment, and only 1% found outside the cells or in the extracellular fluid. They are important in the metabolism of carbohydrates, the storage and use of intracellular energy, and neural transmission. They are also important in the function of the heart, the function of your nerves, the neurons, and muscle functioning. So potassium and magnesium are important in cardiovascular function. In fact, if the patient is having cardiac dysrhythmias, it can be attributed either to imbalance in potassium or imbalance in magnesium level. If you look at the this caricature right here, it's called the hypomagnesemia 7 or the 7 possible causes of hypomagnesemia. One is malnutrition. So malnutrition can lead to decreased magnesium level. Of course, a problem in the absorption of magnesium, the malabsorption symptoms. Metabolic acidosis with renal dialysis or renal failure can lead to hypomagnesemia. Alcoholism, so alcoholic patients will be susceptible to decreased magnesium level as well. If the patient is taking loop diuretics, particularly hydrochlorothiazide or HCTC, then yes, patient will be susceptible to low magnesium level as well. Tetany or tetanic contraction, and can lead to muscular excitability and even tremors. As I mentioned earlier, magnesium is very important in the electrical conduction of the heart as well, almost as important as potassium. So any decrease in the magnesium level of the blood less than 1.5 max per liter may cause cardiac dysrhythmias such as ventricular tachycardia, ventricular fibrillation, or the little torsade. Um, I know if you don't know what torsades means, we can discuss that in med-surg. Hypermagnesemia, too much magnesium level, greater than 5 milligram per deciliter, that's the panic level. And it says normal range is 1.8 to 3.0. A lot of books will say 1.5 to 3.0. It doesn't really matter. Anything below 1.5 is hypomagnesemia. Anything above 3 is considered hypermagnesemia, and of course you have a panic level of 5. Um, Usually, hypermagnesemia is caused by renal failure or excessive intake of magnesium containing antacids like magnesium chloride, for example, or magnesium hydroxide. So if you're taking too much magnesium hydroxide antacid, then it can lead to hypermagnesemia. Watch out for nausea, vomiting, muscle weakness, and hypotension for that. Okay, so non-electrolytes, urea, protein, glucose, creatine, and bilirubin. These solutes don't carry an electrical charge, but they are actually part of the dissolved substances of the fluid. So how do we transport water and electrolytes? How do we maintain, normal fluid balance? Again, if you want to transport water and dissolved substances from one part to the other, or one compartment to the other, then you need to use the water and of course the electrolytes. Um, and there are electrolytes that can help in maintaining the concentration of solution in between a semi-permeable membrane or selectively permeable membrane. One of the most important concepts that we need to understand in transport processes is the principle of uh, osmosis and diffusion. What's the difference between osmosis and diffusion? In osmosis, the water particles move from an area of lesser concentration to an area of higher concentration. And the idea is to equalize the pressure in between a semi-permeable membrane. Whereas in diffusion, it's not the water molecules that will move, but it's the solute or the solid particles will be moving from an area of higher concentration to an area of lower concentration. A good example of this would be the movement of gases in and out of the lungs. Like for instance, if I want to breathe in oxygen, I need to ensure, or the requirement is, if I want to breathe in oxygen, there must be a higher concentration of oxygen in the atmosphere, in my environment, compared to the concentration of oxygen inside my lungs, so that when I breathe in through diffusion, higher concentration of oxygen from the environment, breathing in, it will promote the inward diffusion of oxygen since I have less oxygen inside my lungs. The same way that in order to breathe out carbon dioxide, I need to have a higher concentration of carbon dioxide inside my lungs compared to the environment so that I can breathe out carbon dioxide and promote the outward diffusion of carbon dioxide. So in order to have exchange of gases, then diffusion or the principle of diffusion is critical because again, when you say diffusion, it's the movement of solid particles or in this case gas particles from an area of higher concentration to an area of lower concentration. So in order to promote inward diffusion of oxygen from the atmosphere to inside the lungs, the concentration of oxygen in the atmosphere must be higher than the concentration of oxygen inside my lungs, so that when I breathe in, it will promote the inward diffusion of oxygen. The same way that when I breathe out, the concentration of carbon dioxide inside my lungs should be higher than the concentration of oxygen outside to promote the outward diffusion of carbon dioxide. So therefore, you can probably deduce that if the concentration of oxygen in the atmosphere is equivalent to the concentration of oxygen inside my lungs, then I won't be able to breathe in oxygen because there is nothing that will promote the inward diffusion of oxygen. and there's nothing that will promote the outward diffusion of carbon dioxide. This is the reason why, you know, um, I don't know if you have seen a lot of movies about mountain climbing, or climbing Mount Everest. Um, I'm not really sure how tall Mount Everest is, but I think it's close to 30,000 feet, or about 29,000 feet. And they were saying that, um, at 18,000 feet above sea level, you don't have oxygen molecules anymore. And the reason is because oxygen molecules are hyper smaller, and it has heavier atomic weight. What does it mean? The molecules are bigger, and because they are bigger, they are heavier. So they tend to settle at low altitude area. So at high altitude areas, like more than 18,000 feet, 19,000, 20,000 feet, then you have less molecules of oxygen up there. And if you reach that altitude, it will be more difficult to breathe, because you don't have much molecules of oxygen that can promote the inward diffusion of oxygen. This is the reason why those people who are climbing Mount Everest, they need to bring oxygen out there, because after 18,000 feet, it will be really, really difficult for them to breathe. I always, tell the students, um, you know, if a plane is having trouble at, let's say, 30,000 feet or 40,000 feet, what will be the first thing that will happen? You've seen this in most movies. What will happen is, if the plane is about to crash at 40, 50,000 feet, the first thing that will happen is oxygen mask will drop off from the ceiling of the plane. Why? Because at that altitude, you won't be able to breathe if there is a breach in the, you know, uh, in the cabin. Um, so actually, to be honest, if the plane is crashing at 50,000 feet, and you don't have oxygen mask, you don't have to worry about crashing, because you will be dead before you even hit the ground, since you won't be able to breathe. Um, so, diffusion, again, movement of molecules, solid molecules, from an area of higher concentration to an area of lower concentration. Active transport is when carrier proteins transport substances from an area of lower concentration to an area of equal or greater concentration. But in this case, active transport requires the use of adenosine triphosphate, or ATP, in our energy. So all active transports, such as the movement of sodium, potassium, um, across cell membranes, hydrogen and glucose, requires the expenditure of adenosine triphosphate, or active transport. Filtration is the transfer of water and solids through a membrane from an area of high water pressure to an area of low water pressure. And kidneys usually work using this filtration process, and so kidneys will filter the blood, and the amount of blood that can be filtered by the kidneys will be dependent on the amount of blood ejected by the lungs, I mean by the heart, I'm sorry, in every contraction. So less amount of blood coming out of the aorta every contraction will mean less amount of blood going to the kidneys, and less capability of the kidneys to filter the blood. So again, from high pressure area to a low pressure area, that's how filtration works. I already talked about osmosis earlier. I said osmosis is the movement of the water particles from an area of lesser concentration to an area of higher concentration. And the idea is to, again, equalize the pressure in between semi-permeable membranes. So if you look at this illustration right here, The solution in the lab has more solid molecules compared to the solution in the right chamber. And if these chambers are separated by a semi-permeable membrane, in osmosis, what will happen is fluids from a less concentrated area will be attracted to move to the area with higher solute concentration. And the idea is to equalize the pressure in between that semi-permeable membrane. So most fluids in the less concentrated solution will be attracted to move to towards the more concentrated solution in order to equalize the pressure in between that semi-permeable membrane. Osmolarity is a concentration of solution determined by the number of dissolved particles per kilogram of water. And when you say osmolarity, it just refers to how how concentrated or how diluted the solution is. So if the solution has more solid particles compared to the liquid molecules or the water molecules, then um, the solution is said to be concentrated or with high osmolality, and vice versa. Obviously, if there is less solid molecules compared to the fluid molecules or water molecules in a solution, then the solution is considered diluted or less or low osmolality. So our kidneys are the main regulators of fluid balance. They control extracellular fluids by adjusting concentration of specific electrolytes, osmolarity of blood fluids. So the kidneys are really, really important in maintaining body fluids, and kidneys are working really, really hard every single minute in order to maintain body fluids. I don't know if you realize this, but the kidneys can produce 30 cc of urine per hour. But in order to produce 30 cc of urine per hour, the kidneys must filter about 90 to 120 mils of blood per minute, which is about approximately 6 liters of blood per hour. So the kidneys must filter 6 liters of blood per hour just to produce 30 cc of urine per hour. So imagine how strong that filtering capability is. So I'm not gonna talk much about this anymore. There are certain hormones, renin and aldosterone, that helps in regulating the body fluids as well. I told you earlier, aldosterone helps in the reabsorption of sodium, and if you reabsorb sodium, remember that water will be retained as well. Water usually follows sodium, so the more aldosterone secretion you have, the more sodium will be reabsorbed, thus more water will be retained. That can lead to high um, to edema rather. Vice versa, if um, the uh, the body is secreting less aldosterone, then you won't be able to reabsorb sodium. Thus, you won't be able to retain fluid that can lead to dehydration. Renin helps in the release of aldosterone, and again, like I said, aldosterone helps in maintaining body fluid by reabsorbing sodium. We also have hormones that helps in maintaining body fluid by either helping the kidneys produce more urine or helping the kidneys produce less urine. And we talked about antidiuretic hormone earlier, secreted by the posterior pituitary gland. Remember, antidiuretic hormone is sometimes called vasopressin. The atrial natriuretic factor A and F stimulates secretion of sodium and water by the kidneys. They decrease synthesis of renin. It causes vasodilatation, and a lot of times, it reduces blood volume and lowers the blood pressure. Um, The hypothalamus is responsible for regulating body fluid also by regulating the fluid intake. So in case of dehydration, then the hypothalamus will trigger the thirst mechanism in order to increase the fluid intake of the human organism, thus preventing dehydration um, of the body and preventing concentrated blood or concentration of blood that can lead to hypernatremia. So, in healthy adult, the fluid gains and the amount of fluid loss every day should be approximately equal. So, if your fluid gain in a day is about, let's say, 1.5 liters, then the amount of fluid loss or your output should also be equivalent or at least close to 1500 mils. Imagine if your fluid intake is a lot more than your output, then what will happen to the patient? The patient will be susceptible for fluid retention and, of course, edema and complications associated with edema. On the other hand, if the fluid loss is higher than your fluid intake, then the patient will be susceptible to dehydration. So again, the usual adult urine volume is between 1 and 2 liters per day, or 1 ml per kilogram of body weight per hour. But then again, increased water loss varies largely with the amount of solute excreted with the level of the antidiuretic hormone. During summertime, you would notice that the person will not use the restroom as often as he would during winter time, and the reason for this is because during summertime, some of our fluids will be lost, or some of the body fluids will be lost through the skin pores by sweating, by through breathing. Every time you talk, you're not just losing carbon dioxide, but you're also losing moisture and of course water. That's the reason why um, I always say don't be too talkative, because the more talkative you are, the more susceptible you will be to dehydration, because every time you speak, you're losing some water. Um, Water loss through the lungs by evaporation at 300 to 400 mils. I guess I have to stop here, and I will be talking a little more about um, acid-base balance in the next video. So thank you very much, and I hope you learned something today, and I'll see you in the next video. Thanks. Bye bye.